and have your camera on for the Q&A, please. And at that, we'll pass it over to our, I'll pass it back to you, Camillo.
Perfect. Should we get started?
Yes, that'd be great. Thank you.
Awesome. So welcome, everyone, and thank you for joining and taking some time out of your mornings, afternoons, and evenings. This is a joint webinar that we try to do a couple of times a year between the World Federation of Pediatric Imaging and the ISMRM Pediatric Study Group. We have an outstanding group of speakers and moderators today that should make for a fun time together and fairly educational, we hope. So on the side of the moderators, we have Cesar Alves, who is joining us on behalf of the World Federation of Pediatric Imaging. And on the speaker side, we have Fazio Ferraciolli, who's joining us from Brazil on the side of the World Federation of Pediatric Imaging, and Eva Ratai, who's joining us from the side of the ISMRM.
And on the ISMRM side, we also have Martin Graves from the United Kingdom, and Afacan from Turkey, and we have our moderator, Kumeshnie, Kollapen from South Africa. So with that, we will hand over to you. Thank you very much.
Evening, everyone. Welcome to this pediatric MRI artifacts and mimics session. It's an honor to be a moderator this evening. Just a few house rules before we begin. Please can everyone ensure that their microphones are turned off so that we can hear pleased clearly. Questions can be placed in the chat box and these will be addressed at the end of each session. Please know that this session is being recorded and will be available. So without further ado, I'd like to introduce our speaker, Fazio. She's a pediatric neuroradiologist at the University of Sao Paulo and is a research fellow at Harvard University. Thank you, Sueli.
Thank you so much for the kind introduction. Now I can share my screen, just a second. You can all see my slides, right?
Yes, we can.
Perfect. So first of all, thank you so much for the invitation. I'm really glad to be here. My name is Ferraciolli, and I'm going to talk about mimics in pediatric neuroradiology. For this lecture, I was thinking, which are the most incredible diseases that may mimic pretty much like everything. So I thought about the myelinated disease, especially MOGAD, that we need to keep in our pocket for differential diagnosis. Also HLH, which is hematophagocytic lymphohistiocytosis, and also tuberculosis. So these three diseases, they have so many different aspects of imaging. And I think we should see these cases and keep it in our minds so we can use it later. When we see a different case or a hard case on our everyday life, we need to think about these three differential diagnoses. So the first one that I'm going to talk about is the demyelinating diseases. So how can we differentiate them from other non-demyelinating diseases? And also how can we differentiate them between themselves, like MS, NMOSD, and also MOGAD, which is our main star here because it may has so many different imaging aspects. I think I can hear myself. I don't know if anyone has.
Sorry to interrupt you. If anyone if like your microphone open, I kind of.
Yeah, please. Thank you so much. Yeah, because I can hear myself. That. Sorry. So when you need to differentiate between the non-demyelinating disease and the myelinating ones, what should we look at? We should look at mass effect, also enhancement, because the pattern of enhancement may help you, the distribution, and also the evolution of the lesions. So if we look at the, let me just get this. now I got it. Yeah, I had the figures of everyone. So when you look at the two different cases, we can see the mass effect. So on the right side, we have a demyelinating disease with almost none mass effect for the number of lesions that we have. If this was an infectious of a neoplastic lesion, it would be much more there would be much more edema surrounding it and much more sulcal effacement. So you will have this mass effect on the parenchyma adjacent to the lesions, like we see on the left side of the slide. So this is one lesion, and see how much it is disrupting the parenchyma surrounding it. It had much more edema, it had much more mass effect than all the lesions on the right side. So this is glioblastoma. It had also the imaging pattern of enhancement is different. So this one has a nodular, like heterogeneous kind of enhancement. And if we see in perfusion, it had high perfusion because it was a high-grade glioma. And when you look at the demyelinating disease, in this case, what's an MS case, you see this pattern of enhancement with open ring enhancement. This tells us a lot about this. So if you see an open ring, especially when it goes from the inside.
William, sorry, I think I need to ask you to stop a little bit, just because there are some people, and I see there's a lot of noise here. So I'm just trying to see if you can just mute them.
Okay, thank you so much, Cesar.
Sorry.
No problem.
I don't know, who is the host?
No, I think you're the host, so you may be able to mute them.
How can I? Let's see. Can I like mute everybody?
Yeah, it would be better if you mute everybody.
Okay, perfect. Let me see. I think I got everyone. No?
Yep, that's good.
I still see some colleagues that are, now some are.
I think everyone. Now I think I got it. I think I got it, right? Now it's okay? Yeah, perfect.
Thank you, Sully. Sorry for interrupting again.
No, thank you very much. I didn't know. I forgot that I was I was the host. Sorry. So now, so when you look at the pattern of enhancement, so if you have a lesion with an open ring sign, so this one, you can see that this must probably be a demyelinating disease, and this helps a lot in the differential diagnosis. Also, the pattern of location of these lesions. So in the posterior fossa, if you have this pattern in the areopostrema for NMOSD that I'm going to show you in a minute, or this pattern of involvement of the trigeminal nerve, this is particular specific for the demyelinating disease. This helps us to think about them. Also, the Dawson's perivascular commitment, the Dawson's fingers. So all of that may help us to think about these diseases. And when you look at neoplastic disease that may happen in the same place, usually they have that mass effect that we were talking about. It usually is different, this mass effect from the demyelinated disease. Look at the fourth ventricle. It's happy, it's full. But in this neoplastic disease, it's all crunched and it's all compressed by the lesion. And also the evolution may help us, because in this case, 8 months later, you see this huge lesion that has just grow up so fast, and it is a diffuse glioma of the pons, which is this unfortunate diagnosis. And for the other lesion that was only on the infratentorial aspect, and now it has another lesions. There were plenty of new ones in the supratentorial parenchyma, and also some new lesions in the infratentorial in the bulb. So this evolution of the disease may help us too, because you see, sometimes it shows in the initial phases like one lesion, and you may mistake it for a neoplastic one, but then you have more lesions, you say, oh, this is a metastatic disease, it doesn't make sense. So you may also think about a demyelinating disease. So all of this, mass effect, the pattern of enhancement, the pattern of distribution, and also the evolution of the case. It helps us to think about the myelinating disease. And when we talk about the pattern of distribution, we can also think about how to differentiate between NMOSD, MOGAD, and MS. So MOGAD, which is our star for today, if it has the involvement of the optic nerves, it usually would be more anterior, and also this perineural enhancement that we may see in MOGAD may help us a lot in the diagnosis. It pretty much likes the conus medullaris, also the distal part of the thoracic medulla. So these are the places where we should look at for the alterations. And if we have that involvement, we should think about MOGAD. And for the encephalus, we can have the involvement of the basal ganglia and thalamus more than MS and MOSD, and also the bilateral involvement of the middle cerebral peduncle. That's a key image. So if you see that, you think, probably this is MOGAD, because this is a very particular appearance for MOGAD. For NMOSD, which may be pretty much differential diagnosis, and you know that some cases we do have NMOSD with MOGAD antibody. So with MOGAD antibody. So you need to think about when you see this pattern of involvement of the optic nerve and chiasm, usually the posterior part of the optic nerve. Also, when you have the involvement of the medulla, it would be the thoracic and upper thoracic and cervical regions which are more involved in the MOSD. And also in the brain, you have all these places where you have the receptors for the aquaporin 4. So that's the place where you have the lesions. So periventricular, near the third ventricle, and also here in the bulb, in the area postrema. That's the best spot is the place where you should look for the lesions related to NMOSD. And for MS, we do have that usually, let me just see someone just, oh, here. Got it. Now I keep an eye on the mood. So on the lesions for MS, you do have that distribution that you should look at. So for space, we should look at just a cortical, periventricular with that perivenular distribution with the Dawson's fingers that you can see here with the involvement of the corpus callosum, and also infratentorial lesions. Remember that trigeminal nuclei involvement, and also in the spine. And did I forget something? No, just we got everything. So these 4 regions are the regions that we do have these lesions for MS. And if we have the spine, usually it's just focal lesions like oval or round ones, and they're not longitudinal stents like MOSD and MOGAD. They're usually lesser than 3 vertebral bodies, and that help us to diagnose. And if you have optic neuritis, usually it's unilateral. So this article is really, I think it's amazing because it has all of these schemes to think about. No, I have this, it's weird, it doesn't seem infectious, the lesions doesn't seem neoplastic, it must be demyelinating, which one? And then you look at this and it may help you to get the right diagnosis. So these are the cases which have this specific diagnosis. For MS, you have these focal lesions, and you have also focal enhancement. And here you have the Dawson fingers, really beautiful, with just a cortical and also periventricular lesions. So with the 3, we have the dissemination in space and also dissemination in time, because you do have some foci enhancing and others, older ones that doesn't enhance. For NMOSD, you have that involvement of the area postrema. Usually the child is having recurrent vomiting. Let's see. Let me just activate the mute here. Got it. So yeah, this is area postrema. This is where you should look in the bulb for the lesions related to MOSD. And when you have the myelitis, usually it's long, it's transverse, and you can have these bright spots. So you have some focal areas of higher signal in T2 that are these bright spots, usually seen in NMOSD, and this helps us to think about NMOSD. And for MOGAD, I have told you that it likes the conus medullaris, it likes the unilateral, bilateral involvement of the middle cerebellar peduncles. And if you have the myelitis, it's usually central. But we have all of these appearances for this disease that we should look for. So you have the optic neuritis, the ADAM4, the myelitis, but also the encephalitis. And in the encephalitis, sometimes you have just unilateral leptomeningeal enhancement. And you're thinking that, oh, this is infectious, doesn't look infectious. Then you do the CSF and it's not infectious. So what is this? So it could be MOGAD. And in this case, they also had optic neuritis. This is one of our cases. We did have some small lesions in the white matter, but also some enhancement, leptomeningeal enhancement, diffuse, bilateral, and optic neuritis. This child has been treated for, I think, 1 month with antibiotics and wasn't getting better because it was MOGAD. So you need to think about that. Okay. And this other clinical relevance that we need to think is one child with intracranial hypertension that in the beginning, the clinicians may think it's idiopathic, but then you do the MRI and you see there is this optic neuritis and he has perineural enhancement. Can you see it? And also the nerve is involved. You have enhancement, you have blurring of the optic nerve bilaterally. The child also had these lesions in the temporal regions involving the visual pathways. So you have all of this, and it has MOGAD. So you need to think about MOGAD. And also this is one appearance of leptomeningeal enhancement. You can also think about it when you see encephalitis with this kind of leukodystrophy pattern of imaging. So you see all these lesions with mass effect, with heterogeneous enhancement. It looks weird and it doesn't feel right. It doesn't have that mass effect that you should see in an infectious process. What is this? This was a MOGAD encephalitis. So you also need to think of MOGAD when you see these awful cases like this. So I think it's a lot and there are a lot of letters. So this article may help you to differentiate between the demyelinating disease, all the antibodies, and I know that we probably in the future will have a more defined and organized way of viewing it, because in the last few years there has been a lot of research and a lot of new ideas about the myelinated disease. But remember, MOGAD may have encephalitis and also this leptomeningeal enhancement, and may have some clinical difficulties of really pinpointing what is the diagnosis for this kid. So think of MOGAD in the differential diagnosis. Now we're going to talk about the HLH. I'm going to do it a little bit faster because of the time. So hemophagocytic lymphohistiocytosis, it can be primary or associated with infection, malignancy, and prolonged immunosuppression. It has the hemophagocytosis in the reticular and endothelial system, and it also has all this very difficult and in the specific criteria like fever, splenomegaly, bicytopenia. So sometimes it's really hard for the clinician to think about the diagnosis, and we looking at the image and thinking about it may help to get to the right diagnosis for the child. So also the imaging appearance may be variable and may be unspecific, like white matter anomalies, sometimes confluent, and the differential diagnosis for them would be Aden, encephalitis, toxic metabolic, so a lot. So in this case, you can see these white matter changes like bilateral with confluence of lesions, and some lesions even do have this annular restricted diffusion. That might help if you have that kind of pattern. Also had some leptomeningeal and cortical restricted diffusion that also may help. Another pattern that you might see is these nodular lesions, and sometimes these lesions may enhance post-contrast, and as I have showed you, they may have this annular restricted diffusion that may help us in the diagnosis. For this pattern, you may have the differential diagnosis of demyelinating disease, infections, and other nodular appearances of diseases. This is another case with a nodular lesion with that annular restricted diffusion appearance. So this may help us in the post-contrast phase. You can see this nodular enhancement. Okay. The other appearance that we may see is this leptomeningeal enhancement. As you can think of, oh, this may be a differential diagnosis to MOGA. Yes, exactly. So this child didn't have any changes in T2, diffusion, but in the post-contrast image, you could see this leptomeningeal enhancement, and it was HLH. It can also appear a Klippers-like. So you may have this perivascular inflammation with this small punctate foci, and it can be a differential diagnosis for granulomatous process, vasculitis, lymphoma, the angiocentric form. So you need to think of HLH when you see this kind of pattern. So this child also had, is the same one for the last slides, but after they treated her, for 2 months, she started with a recurrent infection and had this enhancement foci, and after treatment with etoposide, it just vanished. So it's really interesting. Also, another very specific appearance for this disease is a small foci of residual calcifications, which includes pretty much everything, like granulomatous disease, infectious disease, and it has this punctate foci of calcifications, and also this atrophic brain that is also one of the patterns that may happen in this disease. She had also hepatosplenomegalia and the atrophy that may appear. So this is the white matter changes and atrophy. So as you can see, it is kind of highly specific. You may help the clinician with that diagnosis. I think I'm gonna skip to be just say that you have meningitis. This is the typical form with hydrocephalus and with the ischemia. You can also have the tuberculoma, and this one is the tricky one because you may make the differential diagnosis with neoplastic forms, and sometimes they do biopsy this thing without the need for that. So you may help the clinicians to think, no, this is not restricted. It has this lobulated appearance. It doesn't enhance, but sometimes when you treat them, they can have some, it doesn't have high perfusion, sorry, but sometimes when you treat them, they may have this high perfusion. It is told in the literature in the first 2 months after the treatment or during treatment, they may have this because of the neoangiogenesis. It's normal. So you may help the clinician to do the differential diagnosis by imaging with neoplastic disease. So this after treatment, they may also show this really calcified lesions. The miliary one, also the miliary tuberculomas, we need to think about that in the differential diagnosis of neoplastic disease. And you may also have the involvement of spine and of the medulla. And with that, you can think of many myelitis that may be the differential diagnosis. You always keep TB in your pocket for the differential diagnosis. So even if they don't look like they are used to, the typical patterns, you may have these 3 diseases in your pocket for your everyday discussion. And if you have these hard cases, this may help you. If you have any doubts or any questions, just please let me know. I think I'm going to finish now, and thank also Tiago and Jessica, which helped me with those cases, in Dr. Leandro Lucato, especially, and Cesar also. Thank you so much.
Thank you so much, Suli. That was a wonderful presentation and very informative. Thank you so much. I'm going to have a look quickly in the chat box to see if there's any questions. I don't see any questions. Okay, there's one that's just come through. The question is, when following up asymptomatic patients with known inflammatory disorders like MOGAD, NMO, and MS, what are your thoughts on routine use of contrast? Always or only if change is detected?
Yeah, usually we follow the clinical pattern of the child. If she or he has new symptoms, if they think it's an active the myelinated disease, you should do the contrast. But if not, since they're using so many, they will do so many exams, you could do a no contrast and just for follow-up, even if, especially if they're in 6 months period of time. But if it's longer and you want to see if there's something different, I think you should do the contrast, especially when you don't have the clinical information for that patient. But if you have, if it's a regular patient from the university or institution, if you can see if they have new symptoms, then you can especially take out the contrast from your exam.
Thanks very much, Sweli. And I'd just like to make a quick comment. We see a lot of TB cases in South Africa, and there's a vast spectrum of imaging findings from leptomeningeal enhancement, hydrokeph. So yeah, it's a good thing to always keep TB at the back of your mind, especially if there's a history of a patient being immunocompromised or recent travel to Africa. Thanks for that. If that's okay with everyone, I'd like for us to go on to our very next speaker. An honor to have Ms. Eva Maria Ratai. Short bio on her is that she is the director of clinical magnetic resonance spectroscopy at Massachusetts General Hospital since 2003. After completing her doctoral thesis in physical chemistry at the University of Münster in Germany in 2000, and her first postdoctoral position in the Department of Chemistry at UC Davis, she then accepted a postdoctoral fellowship with the Department of Radiology at Massachusetts General in 2002. After completing her fellowship, she joined the faculty of Harvard Medical School in 2004 and is currently an associate professor of radiology at Harvard Medical School. What an honor to have you. Thank you, Ms. Eva.
Thank you so much for the kind introduction. Can you hear me okay?
Yes, we can.
Okay, perfect. So first of all, I'd like to thank the organizers for giving me the opportunity to talk about MR spectroscopy as an aid to difficult neuroradiology cases. Okay, so I don't have any financial interest to declare, but I want to note that I'm on the advisory board of Grants. So here's an outline of my presentation. I'd like to give a brief introduction into MR spectroscopy, talk about metabolites, localization techniques, and some choice of parameters. So clinical spectroscopy is used often for diagnosis to differentiate neoplasms from so-called MRI mimics. And also we can distinguish between different inborn errors of metabolism, since enzyme defects may cause an absence or accumulation of metabolites that we can see with spectroscopy. Once we know what it is, spectroscopy may be useful in prognosis and monitor therapeutic treatment, and I have a couple of examples on that. And then last, it may also change patient management, as it can trigger or intensify workup for metabolic genetic panels. So here's a representative spectrum of an adult human brain. So the highest peak is, becoming. Oh, okay, so, something is weird. So this should be here first. So what are the metabolites that we can actually see? So one of them is myoinositol, which is an organic osmolyte that is predominantly in glial cells. So an increase may reflect glial activation or neuroinflammation. Choline is a marker for membrane metabolism. So the increase is associated with cellular turnover, which you would see in neoplasms, but it's also associated with neuroinflammation. Creatine is a marker for energy metabolism. Phosphocreatine acts as a reservoir for generation of ATP. And then glutamate, as you know, is a neurotransmitter. Glutamine is its precursor, and in excess of glutamate is excitotoxic. N-acetyl aspartate is the most important marker in the brain because it's predominantly in neurons, so that makes it a marker for neural health and viability. And then there should be very little lactate in the brain, but can I, let me see, can I make people, Do I have to stop share to unmute people?
No, you can just over the photo, there is an activate or deactivate.
I see, but I don't know who is. Can I unactivate?
Yeah,
Yeah,
I think it's you.
Everyone.
Yeah.
I'm sorry. I think I got everybody. No, more people. I'm sorry. Everybody mute now. Sorry. Anyway, so there should be very little lactate in the brain. Somebody that I missed.
Yeah, I think it's Dr. Hajamar. It's the one that's, I see that's,
Oh,
I'm sorry for that. Yeah, I cannot mute him.
okay. I think I got everybody. And then last but not least, we can also see lipids indicating necrosis. However, if you're dealing with the pediatric population, so one thing to be aware of is that the spectrum changes a lot with age. So, so when you're born, your N-acetyl aspartate is very low. And as neurons mature, you can actually see that NAA is increasing with age. And then choline, which is our marker for myelination, actually decreases as neurons start to myelinate. And so it's very complicated sometimes in pediatrics because you myelinate from the front to the back, and you also have to keep in mind how old is the child and where does the spectrum actually come from. So talking about localization, so spectroscopy can be done with either single voxel spectroscopy or multi-voxel spectroscopy. So single voxel spectroscopy is appropriate for if you have focal lesions where you place your voxel in the lesion and on the contralateral side, or if you already know what your anatomic region is, that is mostly affected. And often when we do metabolic screening, when we place voxels in the frontal cortex, white matter, basal ganglia, it's easy to perform and results in high signal-to-noise ratio. However, multi-voxel spectroscopy or magnetic resonance spectroscopic imaging can record a whole grid of many voxels all at the same time. And is preferred when the location of interest is uncertain, when you have multiple areas that can be evaluated simultaneously and investigate metabolite distributions across heterogeneous lesions like a brain tumor, or also adrenoleukodystrophy, which I will talk about a little bit in more detail. But you see in the lesion, actually, you have the highest peak is myoinositol, then choline, creatine, and NAA. And when you get further away from the lesion, you have a more normal spectrum where NAA is the highest peak, and then followed by creatine and choline, and then myoinositol. So choice of parameters. So before we go to the fun part, so one more thing that we have to deal with. So at intermediate echo times, 144 milliseconds, longer echo times, 288 milliseconds, you do see a reduced number of metabolites because some of them have already decayed. But your spectrum is easy to analyze. And the good thing is that lactate and lipids, they actually resonate at the exact same frequency. However, lactate is inverted at 144 milliseconds. So this way you can distinguish between lactate and lipids. And lipids should already be decayed at longer echo times anyways. So at shorter echo times, you do see more metabolites. And maybe that is sometimes what you want. You do see glutamine, myoinositol, and lipids. And what we typically do at MGH is we record both because we are interested in all these metabolites, but we really want to know if this is lactate or lipid. So we use it clinically for brain tumors, focal infections, pediatric disorders, these inborn errors of metabolism, ischemia, epilepsy, neurodegenerative diseases, and psychiatric diseases. And the order of which I mentioned them is not arbitrary because in brain tumors, focal infections, and pediatric disorders, these spectroscopic changes are large enough that they're of value in individual patients, where you can make a slam-dunk diagnosis based on spectroscopy if you wanted to. In ischemia, epilepsy, neurodegenerative diseases, these changes are occasionally large enough and may be useful for clinical management in some individual patients. But especially when you go to psychiatric diseases, you have very subtle changes. And they're most meaningful in assessing groups of patients or possibly individual patients who have serum MR So as I mentioned before, spectroscopy is pretty useful to diagnose a tumor, and but how does this MR spectroscopy pattern look like in a brain tumor? So on the normal side, N-acetyl aspartate is your highest peak, and then creatine choline kind of half the size. In the tumor, it looks very different. So you can already see by eye that you have a very elevated choline. That's our marker for accelerated membrane synthesis of rapidly dividing cancer cells. So the elevation of choline is basically a hallmark of brain cancers. It's in fact of all cancers. And then creatine, our marker for energy metabolism, is typically decreased. And then N-acetyl aspartate, our marker for neural health and viability, is either decreased or sometimes completely absent in brain tumors as neoplastic cells kind of replace neuron. Another one that's very important in brain tumors and in general is lactate. So lactate should be in very low concentrations in the brain. You should not be able to see it. However, it gets produced by glycolysis. And tumor cells undergo metabolic switch from oxidative phosphorylation to glycolysis, which is called the Warburg effect. So glucose gets metabolized into pyruvate, and instead of going into the Krebs cycle, it actually produces directly lactate, which then can be seen in the spectrum. So here's an example of a child with medulloblastoma. So you see super high choline, creatine, NAA very diminished, and you also see lactate inverted at 144 milliseconds. And another one indicate breakdown of membranes, which you have sometimes in the core of very malignant tumors, but also after radiation necrosis. And don't forget myoinositol. So myoinositol is this osmolyte that is found in glial cells, and an increase may reflect glial proliferation. So, and people found that it's actually a really good marker in grading brain tumors because it is elevated in in low-grade tumors, and it's decreased in high-grade tumors. So here's an example of a kid who has this lesion in a really difficult to biopsy area. But at least we don't see a lot of choline here, but we see myoinositol. So at least we know that it's potentially a low-grade tumor, not a high-grade tumor. So we use it for diagnosis to differentiate neoplasms from so-called MRI mimics. So what are those? Those could be cortical dysplasias, infections, tumor factor, demyelinating lesions. So here's an example of a 7-year-old developmentally normal boy. A sudden onset of right face and arm twitching, EG showed left parietal slowing and spikes. And the lesion that you can see expands the left parietal cortex, and there is iso-intense to gray matter. There is no enhancement. There was no midline shift. So typically I ask the residents, fellows, and attendings, so what is this? But I muted you all. So anyway, so 99% this favors cortical dysplasia. That, of course, there's always, because it kind of looks like textbook, but there's always one wise guy who says, oh, maybe it's the opposite of what I think it is. But anyway, it looks amazing. And then we did spectroscopy here. So again, so here's the normal spectrum on, NAA highest peak, creatine and choline half the size of that. So you see in the actual lesion, very elevated choline, and NAA is very diminished, and you also see lactate. So, but this looked still too much like a cortical dysplasia for people. So they at least followed the kid very closely during a trial of anti-epileptics. And we got him back a couple of months later. We do actually see that the lesion increased. So now we resected the lesion, and it was actually an enviocentric astrocytoma. One of those should have listened to the spectroscopist in the first place. So we use spectroscopy a lot for inborn errors of metabolism. So, as enzyme defects can cause the absence or accumulation of metabolites. So when you see a lot of NAA, you think Canavan's disease. If you don't see any creatine peak, you think, oh, this could be creatine deficiency. Whenever you see any elevated lactate, you should at least think maybe there's some inborn error of metabolism. And then there are diseases like maple syrup urine disease, where children are not able to metabolize amino acids. So when you see a lot of amino acids, you should think that. And then if you see glycine, it could be also glycine encephalopathy. So here's an example of a 21-month-old boy born without complications after a complicated pregnancy, failed to achieve expected developmental milestones, and physical examination showed generalized hypertonic microcephaly. I mean, the brain is abnormal, but look at the spectrum. I mentioned before, NAA should be double the size of creatine and choline. This is, I don't know, 7 times higher. So slam dunk diagnosis is Canavan's disease. It's a leukodystrophy where you have a genetic defect where the enzyme that breaks down N-acetylaspartate into acetate and aspartate is missing. And you do need aspartate for myelination. So the life expectancy is usually into the teens. And now actually be using this NAA peak as a biomarker in clinical trials. So when children get treated for Canavan's disease, does the NAA actually go down? Here's another example, 2.5-year-old child with mental retardation, seizures, and speech delay. And I already put the big arrow here because some people find it hard because it's something is missing instead of you have too much stuff or something. So anyway, there's no creatine. And the brain looks actually pretty normal. So this is creatine deficiency. And also one of those slam dunk diagnoses based on spectroscopy. But so luckily, this kid had a form of creatine deficiency that can be corrected by oral supplementation of creatine monohydrate. And a couple of months later, you do see, the creatine peak is back. MENAS is also another example where spectroscopy can be helpful. It's a rare genetic mitochondrial disorder with onset typically in childhood, and you do see increased T2 signal on T2 and also increased signal on DWI. And interestingly, we see a lot of lactate, not just actually in the lesion here, but also tons of lactate in the CSF and even in normal appearing white matter. So if there is a lot of lactate, not just in the lesion, so you should definitely think, oh, this could potentially be MENAS. This is a case that kept us on our toes for a couple of days. So this was a 10-month-old boy, normal fetal and birth history, normal development, developed acute gastroenteritis with vomiting, diarrhea, nausea, was admitted to Mass General Hospital, and then had multi-organ failure with encephalopathy. So initially the T2 was read out as normal, but then was revised to advanced myelination. So here I'm showing you the patient, and here is a normal control, which would be also 10-month-old. So there's a little bit of more myelination. So with the spectroscopy, there was a smoking gun. So you do see NAA, choline, creatine kind of normal, but you see this massive elevation of lipids. And I mentioned before, at 288, the lipids should be decayed, and whatever you would see is lactate. However, if you have that many lipids, they're gonna, you still see them even at longer echo times. So this triggered that we realized that this kid had long chain fatty acids cannot be metabolized, and he happened to be creatine acetyl carnitine translocate deficiency. And there's a treatment. So with this Portagon formula, he was actually doing much better a year later, and you see the lipid peaks are gone. So sometimes we know already what it is, but then spectroscopy can help maybe, come up with a prognosis. Or look at certain treatment response, and I have a couple of examples here. So as you know, hypoxic ischemic injury is the major cause of perinatal mortality and morbidity, and typical treatment includes hypothermia, where we cool down the baby to temperature below homeostasis to allow the brain to recover for about 3 days. And the prognosis for any given baby is uncertain, so we do need some reliable markers to see how the baby could be doing in the future. So MR spectroscopy, among other things, has emerged as a potential biomarker where we can look at an increase in lactate and a decrease in NAA, as poor prognostic markers. So here's an example of a 5-day-old baby boy with known diagnosis of hypoxic ischemic injury, so followed hypothermia treatment. The MRI still shows a central pattern of hypoxic ischemic injury, but despite cooling, there's kind of a lot of lactate. So it's much higher than we want it to be. So he had significant motor function delays. And here's a very old case, but I'd still like to show it because it has 2 take-home messages. So number one, so this is a 15-hour-old boy. He had seizures activity. The question was, did he have hypoxic ischemic injury? This was before the time of cooling. So one thing I want to point out is you do see a peak at 1.3 ppm. It's 144 milliseconds. It's inverted. So you do see elevated lactate consistent with hypoxic ischemic injury. There's another peak here at 1.1 ppm. So
ele diz para meter uma está na casa dele, sabe quanto é que isto custa? Ou seja, a Patrícia estava assim, quando falou no rádio, está na casa dele.
Okay, where was I? Okay, so there's this other peak at 1.1 ppm. And it took us some time, and and I called a couple of people up because, as I said, it's a very old case. So we realized it's the diluent of phenobarbital. So and a lot of kids get phenobarbital for their seizures, but there's this diluent 1,2-propanediol that also goes through the blood-brain barrier, and results in a peak at 1.1 ppm, and it also is a doublet, and it also inverts in 144 milliseconds. So just be careful when you see something that's close to 1.3 and the kid was treated with phenobarb, then, could be the diluent. The other thing that I want to point out is that months later, he acquired microcephaly, cortical blindness, severe developmental delay with hypotonia, and we realized he also had a mitochondrial deficiency. So even when the criteria met for hypoxic ischemic injury, just keep in mind that could be in addition also another inborn error of metabolism. So we see a lot of kids with adrenoleukodystrophy disease that leads to accumulation of very long-chain fatty acids. There's an acute form with onset in childhood that leads to inflammatory demyelination, neurological dysfunction, vegetative state, and death. There's a chronic form that's milder with onset in adulthood. So they have typically axonal loss in the spinal cord. However, they can also have demyelinating lesions. And it's not possible to predict the phenotype by mutation analysis alone. So the MRI is actually pretty good in depicting the demyelinating lesion, and it's typically extending from the splenium symmetrically into pituitary white matter. Sometimes it starts in the genome. So we place voxels right at the edge of the lesion, so not in the lesion. So this looks pretty normal, but in this kid, you do see elevated choline and decreased NAA. So the second kid here was progressive, while the other one was non-progressive. So spectroscopy kind of predicts the lesion progression. And these days, we can also we look at treatment response, so because these kids get either stem cell or gene therapy. Recurrent tumors versus treatment effect. They often look similar on MR images, but they're different metabolically. So here's an example of a 9-month-old boy with medulloblastoma in the posterior fossa. So he had a craniectomy, proton beam radiation, and chemotherapy. Was stable for 2 years, and now he comes back, and you do see a lesion in the occipital horn. He was reassessed a couple of weeks later. This time we included MR spectroscopy and perfusion. And while the occipital lobe lesion slightly increased, what you see is choline is not very elevated, just NAA is slightly down. So this is more consistent with treatment effect. And we actually did biopsy, and it was confirmed. So sometimes we don't get a slam-blind diagnosis on spectroscopy, but maybe an increase in lactate prompts or intensifies the workup for underlying inborn of metabolism. So like in this one case, where the kid had mitochondrial deficiency. And here's my last example here. This is a 1-day-old baby boy had seizures with no known diagnosis. The idea was that does he have hypoxic ischemic injury? There were no abnormal findings. We did scan him again 3 months later, and there's still this persistent lactate peak after 3 months. So then we were like, is it maybe an inborn of metabolism? We looked at the genetic panel, and he had a KCNQ2 mutation, which results in benign neonatal seizures, but also more benign, more difficult to treat epilepsies. So hopefully in the last 20 minutes, I could convince you that, spectroscopy is a powerful tool that, to probe biochemistry that adds to the information. So it always adds to the information of obtained by MRI. Spectroscopy can easily be added to clinical MRI scans, and then has significantly impacted patient management in terms of diagnosis, prognosis, and therapies. So I'd like to thank you very much for your attention, and I'm open for any questions.
Thank you very much, Eva. It was a lovely talk and beautiful examples. There is a question in the chat box.
Let me actually, can I make myself no longer host? How do I do that?
Sure.
Because I feel like I can't.
Oh, it's okay. I've done it. It's okay.
You did that already. Okay, perfect. Okay. So yeah, can you see?
Yes, sure. So there's a question for you. It says, do you use post-processing methods for potential quantification of concentrations of the peaks, such as the so it gives an example here, such as the ALSI model, as part of the routine of the MRS studies in your practice, and how important are these methods then for you?
Oh, that's a great question. I did have one slide on quantification, and then I took it out because I thought maybe, So I would say, especially in adults, where we're looking at 2-hydroxyglutarate. So to look at, if they have IDH1 mutations, if they have 2-hydroxyglutarate, we cannot see it by eye. It's impossible. So I run all of those through LC model, and we have a basis set with it in there. And we do, yes, absolutely. But, in some cases, clinically, it's not even necessary to run it through LC model because it's so, slam dunk. But we do a lot of research on the back end, then, looking at like the ALD cases. They have to be, because if you want to publish anything, you have to run it through LC model. Yes, but it's LC model what we use. Yes. Thanks for the question.
Thanks, Eva. Thank you. I have a quick question. The adrenoleukodystrophy case that you showed us, was the reason for placing the voxel in the periphery of the lesion because that's the active itch?
Oh yeah, so that's the cool thing. So we do multi-voxel spectroscopy, right? I think I'm no longer sharing my slides, otherwise I could go back. So we do multi-voxel. So we do include the lesion. We use the juxtalesional areas and also normal appearing white matter. And it is, so the lesions always look bad. So you always have super high choline, super high myoinositol, very little NAA, sometimes lactate. But it's the juxtalesional spectroscopy, right, where it is normal again. If there the choline is high and NAA is low, that is predictive of what's going to happen in the next couple of months. So I think we wouldn't do a single voxel spectroscopy because then we would do like 10 would take too long.
Thanks, Eva. Thanks very much. If there are any more questions, I'm now going to hand over to my colleague, fellow moderator, Cesar Alves, to introduce the next speaker. Thanks, Cesar.
Thank you. It was a great lecture, Dr. Ratai. And the question was mine. It was quite knowing about how you use these models in your clinical practice, because we normally use them, but not always, as you said, not always necessarily. Okay, so let's move on to our next speaker, Dr. Martin Graves. Dr. Martin Graves is a professor of magnetic resonance and physics at the University of Cambridge. She's also a senior fellow in ISMRM, and since 1984, and also co-author of the MRI textbook From Picture to Proton. So I kindly invite Dr. Martin Graves to talk to us about MRI artifacts. Dr. Martin Graves.
Thank you very much indeed. Let's hope I can get to sharing here properly. Oh, seem to have started right in the middle. Look at that, giving all the game away.
Yes.
Let's get there. Okay, is that okay for everybody?
Yeah, it's perfect, Dr. Martin.
Okay, well, thank you very much indeed. And again, I'm
yeah, we may have some issues. I think we may need to ask again. I don't know if you will be the host or someone will take care of muting the colleagues that unfortunately are not muted. Sorry for that.
yeah, don't think I can mute other people.
Yeah, just look, over the picture, it has an activate and deactivate.
Sorry, whereabouts was this?
I think probably, I think everyone, let me check.
Hopefully it's good.
Yeah, it's good.
Okay. I need to go back to sharing screen again. No. I can only see myself now. I've lost my view of my slides. Hey.
Should be there now, Martin.
I seem to have lost them completely. All I can do is see myself, which is quite a scary thought. There's,
Are you a host again?
yeah, share screen. Okay, let's try that. Right, good. Let's hope we can go from there. So thank you very much indeed for the invitation to speak to you. So I have no financial interests regarding this presentation. So when we think about MRI artifacts, I think about them as this sort of three circles in this Venn diagram. We have the physics of the situation, so that's really Fourier encodings, maybe the electrical properties of tissues, tissue relaxation, T1, T2, T2 star. And then, of course, we have the MR system hardware. That's the magnet, our static magnetic field, B0, and non-uniformities in that. And then we also have the magnetic field gradients, GX, GY, and GZ, and issues associated with those, as well as the transmit and receive RF side. And then, of course, we have the patient, and the patient may have motion, involuntary motion, or even voluntary motion. We may have blood flow, and then we have things like magnetic susceptibility, as well as different tissue types. So really, any sort of artifacts could be arising from one, two, or even three of these different sources all combining together. And of course, there's a large number of artifacts, so hopefully the few that I've chosen to present today may give you some insights into their sources. I think we'll start with the basic principles of MR acquisition. And although there are these other non-Cartesian methods, I'll just concentrate in this presentation on Cartesian methods, and particularly the method of which most MRI images are acquired, which is the spin warp technique. So here's a spin echo sequence. There's the 90-degree excitation. Don't worry about the fact that's flipping around. There's the 180-degree refocusing pulse. We have a slice select gradient, a slice select for the 180. We have a readout gradient here when we're acquiring the echo signal. And we also have here this phase encoding gradient. And that phase encoding gradient changes amplitude on each TR period, and we build up our picture of the raw data like this. And I'm simultaneously, although it doesn't normally happen on your scanner, but simultaneously reconstructing the image as we acquire the case space. So you can see that the edges of case space just give rise to the edge detail in the image, the outer ring of the skull there. As we approach the center of case space, we get the bulk of the contrast in the image. And actually, we only need to acquire just over half of case space to get a pretty good image. And then acquiring the other half of case space, we're essentially just improving the spatial resolution. And this is really the spin warp method that was originally developed at the University of Aberdeen. The two people here are the late, great Bill Edelstein, here shown standing next to the magnet, and Jim Hutchinson there, who's lying in here. And so spin warp, I think they were both Star Trek fans. It's really the method of choice now for the acquisition of MR data. And this relates to some of the artifacts that we'll see as we go through. Now, we just need to think firstly about the inverse relationship between case space, our raw data space, and the image space. So particularly the fact that the extent of case space is inversely related to the pixel size, whereas the spacing between samples in, for example, here in the X direction, in the frequency direction, and here in the phase encoding direction, you can see those differences now are inversely related to the field of view. So it's the spacing that affects the field of view and the extent of case space which dictates the pixel size. So here, after Fourier transformation, image reconstruction using the spin warp method, we can see now the field of view in the X and the Y. And if we just zoom into this region here, we can see we can get down to the overall individual pixel size dictated by the extent of case space. So here, one example, if we acquire a matrix of 256 by 256, there's our case space data. And here, if we acquire with a matrix of 512 by 512, obviously you can see now that we've extended case space in both dimensions. So even though both these images after reconstruction have the same field of view, the fact that we've got double the resolution or double the size of case space here means that we've doubled the resolution. So this matrix with 256 millimeter field of view, we've got a 1 millimeter pixel size. And here we've got a 0.5 millimeter pixel size. So here on this resolution phantom, now if I just zoom up the other image here, just to make it a little bit easier to see, hopefully you can see these resolution holes, and that the resolution, for example, is much better now in our 512 acquisition than it is on our 256 acquisition. We can't separate out these 5 holes here, but they are easily separatable here in both the phase encoding and the frequency encoding directions. So this allows us to do things like if we acquire our only 128 phase encodings and we acquire 512 samples, then manufacturers will normally just fill the periphery of case space here with zeros. So that's essentially the best possible interpolation that can be done. So now we've got a 512 by 128 acquisition, 0 filled to give us a 512 by 512 case space, again with the same resolution or the same field of view. And now if we look at those images, we can see that we do indeed have 512 pixels in both directions, but clearly we have a very different resolution in those directions. So if I zoom up here, you can see that in the phase encoding direction, this way, we can just resolve these particular spacing here. One line down, we can't resolve that at all. And here, now we can resolve a much higher spatial discrimination, frequency encoding direction. So essentially, the true pixel size here is actually 0.5 by 2 millimeters. The interpolated pixel size is 0.5 by 0.5. So we actually have elongated voxels in the phase encoding direction and small voxels in the interpolated image here. Again, may I ask whoever's just there if they could also mute their microphones, please? Thank you. So, yeah, some people still can't quite get the idea. I don't know what else I can do to try and stop people from...
Martin, I'm just stepping in to mute. I won't be long.
Thank you very much.
I think we're good. I was going to hand it back to you.
Thank you very much. Let's see if I can. Okay, you disabled screen sharing for me as well. Just have that back.
Yep.
Hopefully in the same place. Okay, thank you again. So it's important to understand the differences between the true pixel size and the interpolated pixel size. Again, you know, that may be quite important in coming to your diagnoses, and particularly if you're using small fields of view or require high resolution for pediatric studies. One of the consequences of having that low number of phase encoding steps here is that in the phase encode direction, we get these artifacts here, these parallel lines, as you can see here, which we don't really get in the frequency encoding direction because we've acquired more Fourier components or more points in that direction. And this is often known as Gibbs ringing or truncation artifacts. And this arises essentially because if we try to capture a very sharp edge, such as I'm doing here, what this movie is showing you is the necessary sines and cosines, the Fourier components that make up a square wave. So as we add more and more odd harmonics of these particular amplitudes, here I'm just drawing them all together and just showing you each one of them here. When you put them together, you can see we can actually synthesize a square wave. However, things are not perfect, and we can see that we get these fluctuations here near the sharp edges of the square wave. And this is essentially what we're seeing here. When we don't have sufficient Fourier components, you can see these modulations at the edges here, particularly easily seen here on the bright side of the phantom. And therefore, those are contributing to the ringing that we're seeing. And there, if I take the 256 by 128 and compare it with the 256 by 256, you can see that although there is still ringing there, the amplitudes are much less than what we have here with only 128 phase encode samples. And those, for people who aren't familiar with this is actually Josiah Willard Gibbs, who was a very eminent American scientist for whom actually Albert Einstein called the greatest mind in American history. And it was really work that Gibbs did back in 1899, which was published in Nature, where he actually described these overshoots at a point of discontinuity or at an edge. And the archetypal example normally for Gibbs artifact is this kind of example here, where we think we may actually have a syrinx. There actually isn't a syrinx here. It's simply because of this bright interface between the CSF and the spinal cord and those fluctuations that end up showing a slightly lighter line down here in the cord. If we look at a modern MR reconstruction using deep learning, which has learned how to suppress Gibbs artifact, then you can see that simply post-processing or reconstructing this data with a deep learning algorithm, it's completely disappeared. So this is entirely artifactual. And they're just zooming up to make it a little bit clearer. So as I showed you at the beginning, most of the issues we have here are related to the fact that this phase encoding gradient gets stepped through from a negative value to a positive value, or in some other order, depending on how we acquire our data. So here, just in cartoon idea, I just want to show you quite what the effect of the phase encoding is. When we have the maximum negative encoding gradient, if we just look at that there, for example, here's the phase encoding, and we see that that phase encoding allows us to acquire a echo signal which goes into the edge of k-space because it's the maximum negative phase encoding. And that maximum negative phase encoding, as that spin warp name suggests, actually puts a warp in the phase of the spins across the field of view in k-space. So what we actually have here is a sinusoid here where we've got a 180-degree phase shift between adjacent pixels in that phase encode direction. And then if we change our phase encoding gradient to one slightly less, then we're doing another line of k-space. And as I said earlier, the distance between these is inversely related to the field of view. And if we continue stepping this through all the way, each step of the phase encoding, we acquire an echo, and the frequency encoding data from there gets stored in k-space. This is the line of k-space which is just near the center here. We don't actually sample the center, but this happens to be 2 away from the center. And now you can see that because that's a much lower amplitude and there's much smaller area, we now have 2 cycles across the field of view. So this is the n-2 phase encoding step. If we go one more, the n-1, you can now see that we've got 1 cycle of phase shift across the field of view in the phase encoding direction. And then if we go to the +1, exactly the same, 1 cycle across the field of view, but we've simply now inverted the phase relationship from the -1 to the +1. And then again, there's the second case, exactly the same as we have here, except now we've just inverted the phase from these. And if we carry on now with the phase encoding step moving up to the maximum positive value, shown as here, we're again back in the same situation where we've got half the number of phase encoding steps and we still have this 180-degree phase shift between adjacent pixels. So that's really the basis of phase encoding. So remember that phase can't be limited. So even though I've just drawn 1 phase cycle here, we have phase continuing on throughout space. So this explains a lot of the reason that we get phase wrap, sometimes known as aliasing or fold over in particular images. So here, for example, we've got a slightly reduced phase encode field of view, so it's slightly more than one phase cycle across here, and that phase variation continues. So if we look at this particular maximum intensity projection from an MR angiogram, part of this means that because we have the same phase shifts, we've actually got the body wrapping in here, but we've also got this strange, well, I don't know quite how we describe it. It was originally described here as an anastomosis. But if we look at our phase shifts here and know that it's going to shift from outside, what we've actually got is clearly something outside of the field of view that has wrapped around and into the image. And I'm sure people can probably guess what this is. This is actually a gadolinium infusion line for the contrast enhanced MRA. So it's out here, we've chosen a too smaller field of view. The infusion line is lying outside and has wrapped around into the image. We can see clearly there 1 cycle where it positions itself in here. And we get the same phenomenon happening when we do three-dimensional acquisitions. So in a three-dimensional gradient echo, although we have the standard phase encoding gradient that we've talked about before, we also now have a second phase encoding gradient in the slice select direction. So we excite a slab of tissue, such as here, but then we use these phase encoding gradient steps here in the slice select direction to encode separate K spaces in Z as well. So now we have our standard KX, KY, but we also have a stack of raw data in the KZ direction. So following a three-dimensional Fourier transformation from there, we end up with images like this, just cycling through this gradient echo series with relatively thin slices here, because we have the benefit of a very thick excitation and doing these multiple KZs. So even though the acquisition time is going to be longer, although the advantage with gradient echo is we can have a very short TR, it does mean that we end up with these three-dimensional data. And so if we look at the reasons for getting slice wrap, in this case here, if I, for example, set up a set of coronal images, this case here, you can see that the slab profile of the RF pulse used in this three-dimensional acquisition is not nice and sharp. So although we have these slices here within the profile, some tissue at the back and the front here is also going to get excited. And so when we do that, of course, we've got phase that continues to vary in that direction. So we can't separate out where the phase is from those slices here. So if they've been excited, essentially the ones here with this particular phase value will simply get aliased to the point inside the field of view with that phase value. So therefore, we end up with the back of the head wrapping around to the front of the head like this. So again, normally why some manufacturers will just throw away a couple of slices at the extremes of these. So if you acquire 64 slices, for example, you may only get 60 slices reconstructed, because the manufacturer will deliberately throw away 2 slices at either end because they are expecting those to demonstrate this wrap phenomenon. The other area that often gives rise to artifacts is motion. So in this case here, I've acquired some very rapid imaging here, so essentially real time. So you can see as the patient is breathing, we can see the liver moving in and out of the slice. But here, this spin echo or fast spin echo acquisition has taken a number of respiratory cycles to acquire the data. And because of this movement, even though the movement is primarily through the screen here, that still propagates as artifacts in the phase encoding direction. And that's because the phase encoding is performed every TR period, and every TR period is much more commensurate with the time interval of structures moving. In the frequency encode direction, we can normally acquire data in a few milliseconds, say 8 milliseconds, something like that. So there's very little time for motion. But if you have a TR that is going at, I don't know, let's say, 2 seconds, something like that, then you know that the organs will be in a different position from every 2 seconds. So therefore, after reconstruction, these variations end up as these ghosting artifacts. So if we look down in a bit more detail, why do we not see ghosting in this fast imaging? Well, because we're acquiring all of our lines of K space very rapidly, and therefore each frame of this movie, the diaphragm really hasn't moved during that time period. So the signal amplitude over that time period is essentially flat, and it's not changing. And the thing that MRI hates most of anything is for data to change during the acquisition. So if we've got a nice standard uniform response, after Fourier transformation, that just appears as what I will call a primary source, essentially this image. So we've got a very nice clean image with no, as you'll see in a moment, side bands that are arising from the motion. If we look at the situation where we've got respiratory motion now, so there's my respiratory waveform, you can see now that when we acquire the data, we're actually collecting data where there is substantial variation in the signal because of the motion of the liver and the diaphragm through that imaging slice. And when we now Fourier transform that data, not only do we have our primary, but we also have these side bands at multiples of this physiological frequency. And it's possible to actually derive exactly what the frequency or the time interval between respiratory cycles is from the spacing of these ghosts. But essentially, we've got our primary image, which is here, and then we have these symmetrically placed ghosts, as you can see very clearly here, due to the respiratory motion. So often, so an example of just showing it there. So often we will go to respiratory triggering. So the reason that respiratory triggering works is now because we only acquire data when we're in a relatively quiescent or stable position of the respiratory cycle. So of course now the data is again back to being completely uniform, no signal fluctuations over each phase encoding step. After Fourier transformation, we just have our primary object in there. And then when we look at that image, excuse me, that is pretty good without any of those horrendous motion artifacts due to respiration. Another example of flow artifacts is pulsatile flow. These are the same images. I've just windowed the one here on the right just to accentuate them. But here we have pulsatile flow in the descending aorta or the abdominal aorta here. And look, we can see discrete ghosts from that pulsatile flow in the phase encode direction. So how do we try and deal with that? Well, in many cases, this is due to phase shifts during the acquisition. Now, I hope I'm not baffling people too much, but when we acquire our MRI data, we actually acquire it in what we call quadrature. And after Fourier transformation, this quadrature essentially means that we acquire complex case-based data. So if people remember back to complex numbers in school, thinking that you'll never have any use for them ever, well, here's a real practical application of using complex numbers. So we acquire both real and imaginary components. Now, the vast majority of the time, we simply acquire or we simply calculate the magnitude. So all of our standard MR imaging is primarily looking at the magnitude of this complex data, the length of that green vector there. So that's simply the imaginary squared plus the real squared, all square rooted. We get a very nice standard image. But of course, there is this possibility of determining on a pixel by pixel basis exactly what the phase shift happens to be. And here is a phase image, which for the mathematically interested is simply the imaginary divided by the real. And we take the inverse tangent or the arc tangent of that. And then on a pixel by pixel basis, we've got a phase map. Now, most of the low frequency variation, bright or dark to bright, you may see over here is due to the fact that the magnetic field is not perfectly uniform. In fact, phase images are used as part of the shimming process. Excuse me. Here we can see there's lots of aliasing because this is phase data. And this aliasing is coming here because of the air tissue interface at the sinuses. And that also upsets the phase relationship. So we've got this phase information. Now, if we look at a typical gradient echo, for example, or any pulse sequence, we can see here in blue, I have a trapezoidal gradient waveform, maybe the slice select or the frequency encoding. When you apply a magnetic field gradient, the spins will process faster, but at the end of the gradient, they will have gained phase proportional to the amplitude of the gradient, the position of the spin, and time, as the gradient is applied for a period of time. Now, when you've got spins which are moving, for example, with a constant velocity, they also gain phase, but they gain a greater phase because it's now proportional to the gradient strength, the velocity, and because velocity is a function of position and time, it now becomes squared or quadratic with respect to time. So therefore, we have this large velocity-induced phase shift as well as a static phase shift. And really, it's this velocity-induced phase shift that gives rise to these ghosts. Now, in a standard pulse sequence, you can see that we normally have a pre-phaser here and then the readout gradient, and the center of the echo occurs in the middle here. So the area under here matches this area. Similarly, for the slice select, if we start at the center of the RF pulse, that area of the gradient is matched by this rephasing gradient here. So if I just look at a gradient here where we've got identical areas, you can see that the stationary spins gain phase, and then with the negative gradient, they lose phase, so that at the end of this particular gradient waveform, or here, there is zero phase shift. Now that's essentially in the slice select because we don't want a phase shift across the slice thickness. Otherwise, we just wouldn't get an image. We just have signal cancellation. And we need zero phase shift at the center of the echo here to actually form our gradient echo. Now, if we apply something called gradient moment nulling or flow compensation or velocity compensation, depending what it's called on your particular MRI scanner, what happens is additional gradients are played out now so that we actually have essentially 3 lobes. Now, essentially, this lobe here is the opposite of the lobe we have here. So if you imagine those 2 lobes followed by equal but opposite 2 lobes afterwards, this area and this area added together equals the area, or the negative area. Now, you may have to take my word for it, but if you look at the maths of this, the stationary spins gains phase, loses phase, and then regains phase. So it's got zero phase shift at the end of the gradient waveform. And similarly, in this case, spins moving with a constant velocity will also gain phase, but then because of them moving with time, they will also have zero phase shift at the end of this particular gradient waveform. So here's what the gradient looks like. It now has 3 lobes associated with it on frequency encoding and slice select. Different things are called, different manufacturers, they call them different things. So we can think of these for stationary as the zeroth order moment, and for moving spins, the first order moment. So in the standard acquisition, without these additional gradients, we have a zeroth order moment. So everything nicely lines up for stationary spins, but we have these ghosts. Whereas with nulling the first order moment or velocity, so m0 is 0 and the first order moment is 0, we get rid of those ghosts and we only have that primary. So again, the way to try and deal with these pulsatile flow artifacts is to invoke gradient moment nulling, flow, or velocity compensation. And here's an example, particularly now, this is not a pediatric case, but just to illustrate the effects here, this is in a fast spin echo T2, and you can see that we've actually got signal loss here due to turbulent flow or high velocity flow within the cord. But if we apply flow compensation, because this is fast spin echo, we apply it in particular directions. But here in the frequency encode direction, if we can do that, we substantially reduce that artifact. Because this is now encoded with the phase encoding this direction, we use these saturation bands to try and minimize swallowing and respiratory motion from causing artifacts in this direction, which works reasonably well. A bit more of a pediatric example now, but you can see here CSF flow artifacts in this 3-year-old girl. And despite having flow compensation in the frequency encoding direction, SI, we still haven't eliminated those. So it may have been that we needed to also apply a flow compensation in the slice select direction in this particular case, and hopefully that would have eliminated these signal dropouts. And the final artifact that hopefully I've just got a brief time to talk about is these water-fat swaps that you often see here. This is in the case of a Dixon technique, whereby we acquire images both in and out of phase, where the water and fat are, say, in phase, but due to the chemical shift of fat, at times they appear in and out of phase. So you may see these in phase and out of phase images. That information can be used to actually calculate images of water and images of fat. And in this case, at the level of the diaphragm, due to magnetic field non-uniformities there, the calculation that tries to separate out these has additional phase terms in it, and it's not essentially corrected those in the right way. So we've ended up with the water signal in the fat image and the fat signal in the water image. And this is a very nice example, courtesy of Dr. Greer, here showing this particular patient who had paraspinal cysts, but just happened to be in the particular acquisition they did here. They were suddenly alarmed by this high signal seen here. But again, this is simply an artifact of water-fat swap, although obviously much more subtle than the previous example showed previously. So again, you need to be aware of these effects, and maybe even looking at the in-phase and out-of-phase images if you can reconstruct those. And again, just a couple of coronal examples, courtesy of Dr. Greer, showing that there really wasn't any pathology in this left lumbosacral region. So in summary, artifacts are a complex mix of MR physics, system hardware, and the patient. And you've got to remember that the source of an artifact is often during data acquisition, so will apply or will occur during case space or raw data collection, and hence the appearance of an artifact in an image is often due to the effects of the Fourier transformation. With that, thank you very much indeed. And I shall endeavor to
it's a very great lecture.
Stop sharing. There we are.
Yeah, thank you for a great lecture. It was very, very good. And I think we have just one question for you in our chat. The question is, does flow compensation come with any time penalty?
That's a very good question. And essentially, as you may have seen from the diagram there, it does increase the minimum echo time. Or if you're doing it in phase or in turbo or fast spin echo, it will increase the echo spacing. But other than that, there's no effect really on overall scan time, unless there's a marginal increase in TR with your increase in TE in a gradient echo. Okay, thank you.
Thank you for your answer. If there are no other questions, I can move to the next speaker. Okay, so now I'm glad to present Dr. Onur Afacan. Dr. Onur Afacan will be talking about advanced acquisition strategies to mitigate artifacts. Dr. Afacan is originally from Turkey and now is assistant professor at Boston Children's Hospital, Harvard Medical School. Dr. Afacan, the podium is yours. Thanks so much for accepting the invitation.
Thank you very much for the invitation. Can everyone see my screen?
Yes, we can see your screen.
Okay, thank you very much. I would like to thank everyone for the invitation. Today I will talk about, following the nice talk by Dr. Graves, I will talk about some advanced acquisition strategies to mitigate some of the artifacts he talked about. I have nothing to declare. Okay, so I picked 3 main artifacts that I labeled as motion artifacts, susceptibility artifacts, and RF transmit artifacts. And I will talk about some current clinical practice, give some examples, and suggest some possible solutions. I would like to start with, in my biased view, the most important pediatric MRI artifact, which is the motion. As you can see, in some cases, it's not possible to eliminate motion, and so you have to generate strategies to correct for motion. So, and this is actually a very costly problem. Jalal et al. In a nice publication estimated that the cost per scanner is more than $100,000 per year. If you think about how many MRI scanners are in the world, this is actually a huge cost. We also did one study where we investigated how do children move. And we basically measured motion using an electromagnetic tracker. And we let the radiologists grade the images. And then we looked at correlations between how the children move and the image quality. One of the first conclusions is 18% of the cases that we imaged would require like an extra sedation step. So the images were completely undiagnostic. And another conclusion we had was motion-free time and average displacement were the 2 metrics that highly correlated with the outcome. Okay, so what's the current clinical practice? Unfortunately, the current clinical practice is mostly sedation and anesthesia. Here I'm showing our results from Boston Children's Hospital. And if you look at the table here, you can see that almost all the 1 to 3 years old are sedated at Boston Children's. And sedation is costly. It has higher longer visits and wait times. There is like a risk-benefit analysis. And as I said, it's the most common practice for 1 to 6 years olds. So one strategy we have to image patients without sedation is what we call feed and wrap. So, but this is only for patients that are under the age of 9 months usually. So families arrive 1 hour prior to the scan. They do like 3 hours of fasting. They feed the baby prior to the scan. We swaddle them, rock them, and we hope that they go to sleep. This actually has like a quite high success rate. But as I said, this doesn't work on older children. We also have developed some techniques to make sure that they get familiar with the MRI. So one of them is the mock MRI. We can play real MRI sounds, and the child comes to the scan 1 hour early, and they go to the mock MRI scanner, and they have the experience of an MRI. And so we hope that this will increase the chance of the child not moving. We also have MRI scan rooms display themes. Like, as you can see, we have a sandcastle. We also have fish aquarium environment. And we also can show LCD and goggles. We also show movies through LCD and goggles to make sure that they don't move. This is great, but if the child is willing to enter the scanner, so our best option is probably measuring head motion in real time and correcting in real time. So I will talk about some motion measurement technologies and correction strategies, and I will give examples of the techniques that made it to the clinical practice. So the first motion measurement technology is external sensors. And there's actually a nice review paper that came out in 2023 by Bruno Modore, if you have if you're interested in this. So one of them is optical trackers. Basically, there's a camera watching your kid, and there's like a marker. And as the marker is moving, you know how the motion is happening, and then you can correct for it. There's like electromagnetic trackers that are like coils that we use in our study. And as the subject moves, there's some current induced on these coils, and we can measure motion from these measurements. And there are also more complicated devices. These are quite close to what you have on your iPhone or like your cell phone, where there's like an accelerometer and there's like a different magnetometers, and then you can measure motion with these. There's also some acquisition-based solutions. I think most of you are familiar with the navigators. Actually, there was some nice examples in the previous talk about like navigators for breathing motion. And there's some self-navigated sequences. You probably heard about spirals and radials, and that's about that. And there's some data-driven approaches which are becoming more and more popular. I think this will come to a scanner near you in near future, and this mostly now involves deep learning reconstructions. So what's a navigator? A navigator is additional acquisition of a part of case space or part of image space. There's like a huge field. Some of them made it to the clinical practice. Some of them hasn't made it to the clinical practice yet. One of them that made it to the clinical practice is the diaphragm navigators. One problem with the navigators is that you usually need to modify the pulse sequence, and these usually increase the scan time. So here are a couple of examples of navigators. One of them is like a VNav. So this hasn't made it to the clinical practice, but it's actually being used in some of the high-level research studies like ABCD, HPCD, and studies like that. And the idea is, let's say your sequence, you have like a RF pulse, and then you have a readout, and let's say that you have a gap. You can basically put like a 3D EPI volume as a navigator, and they look like this. And as the kid is moving, as the subject is moving, you can get these images and register them to each other and get the motion parameters. One thing that we have been working on recently is FID navigators. So these acquire a single point in case space. It doesn't require any encoding. It's ultra fast, but it requires calibration. And if you basically, the idea is as the kid is moving during the scanner, his or her head comes near the coils, and those coils have like an increased signal. We basically can model these signal increases, and we can calibrate a matrix, and then we can estimate motion measurements from these single point navigators. The next topic is self-navigated sequences. Basically, these sequences use case space, some part of case space or image space information that's repeated through the shots. Usually involves oversampling of the case space center. For example, in radial, all the lines are passing the case space center, and you can estimate some motion parameters from this case space center. Again, there's a trade-off between accuracy, scan time, and motion robustness. Okay, from the examples that made it to the clinical practice, one of them that definitely made it to the clinical practice was suggested by Pipe et al. In 1999. It's called Propeller. In some vendors, it's called Blade. So it's basically, instead of acquiring the full case space, it acquires small blades, and then it rotates the blades in case space. So each shot is faster and more robust to motion, and the center of the case space again can be used to estimate motion, but this as a disadvantage increases the scan time. So here's an example without propeller, which is acquired during the standard Cartesian fast spin sequence, and here's with propeller. These scans have the same motion. As you can see, blades has almost no motion, shows almost no motion artifacts. Another one that almost made it to the clinical practice is GRASP or XT GRASP. And this basically mostly used in body MRI at the moment. And this is like a 3D stack of stars. So you get like disks of radial images in case space. And what you can do is self-navigation from radial imaging. Again, you use the center of the case space. You plot the signal from the center of case space, and it looks like a sinusoidal signal like this. And you can assume that this sinusoidal pattern follows the breathing pattern. And you can divide this into motion states. So for example, here's on the left is like a no motion corrected scan. And as you can see, as the patient is breathing in and out, the liver is almost in two positions, like inhale and exhale. And then when you divide this into different motion states, you can have almost motion-free images from each state. So another approach, as actually was highlighted in the previous talk, is single-shot sequences. And usually this is called SSFSE or HASTE. And this is mostly used in abdomen imaging, but it's currently the state of the art in our institute for fetal MRI. And one technology that we developed with some other colleagues is a technique that combines multiple single-shot T2-weighted images acquired in different orientations to a motion-free high-resolution image. And here's an example. So in these ones, since this is a single shot, in the axial, which is the original acquisition orientation, the images are good. But when you look at the sagittal and coronal views, you see that the images show great motion artifacts. So what we can do is we can acquire like an axial image, sagittal image, and coronal image, and we can combine these into a 3D reconstruction. So what other ways we can use motion? So I will say the current state of clinical MRI is repeating scans. So technologists or radiologists look at the images and they decide to repeat the scan. And as I said, although this is the current clinical practice, it does have a huge cost. And we actually showed in our previous work that it's possible to find metrics to estimate image quality from motion measurements. So this way you can repeat the scan even before the scan is finished. So in the middle of the scan, if you know that there will be motion artifact, you can stop the scan, you can talk to the patient and repeat the scan. One interesting approach was recently suggested in 2018 by Green et al., which is giving the motion information as a feedback to the child. So for example, assume that the child is watching a movie and they move. So basically you put like yellow or red signs in front of the movie. And since the child wants to watch the movie, they should in theory stop moving. They've actually showed that in functional MRI studies, this really improved the results. So if you have motion information, you can correct for it. If you remember the previous talk, we usually get phase encoding lines in like a Cartesian trajectory like this. And if there's motion, if there's translational motion, there will be like linear phase shift in these measurements. But if there's rotational motion, it will be like a rotation in K-space. So for example, here in this example, in the first 3 lines, the patient is still, and then they rotate their head or their body. And you see that there's a now gap in K-space, which will create motion artifacts. What we can do is we can, instead of taking a standard Fourier transform, you can get like a non-uniform Fourier transform and get like motion-free images. So for example, here's an example from one of our studies. The image on the left is a no motion case. The image in the middle is a motion case without correction. And the image on the right is motion retrospectively corrected using our FID navigators. And as you can see, although the images still show some slight artifacts, it's much more improved. Another thing that we can do is feed back to motion information in real time back to the scanner. And this way, we eliminate any artifacts like the gaps that I showed you in the previous slide. And here we can see that when we feed back the motion information from the FID navigators, if you look at the bottom 2 images, the one on the left is no motion correction, and the one on the right is prospective motion correction, and shows much reduced motion artifacts. So the next topic that I would like to talk about is susceptibility artifact. So when we are imaging, we assume that all the spins are rotating with the same frequency. However, susceptibility difference between tissue, for example, in the brain, the tissue between the air and the bone results in frequency changes in the voxels. This is especially critical in echoplanar imaging sequences like used in diffusion MRI due to the low bandwidth of the sequence. So here I'm showing 2 examples from one from a brain example and one from a kidney and liver example. So this image, you can actually see the motion artifacts. These are all motion artifacts. But the thing that I'm highlighting is because of the air in the sinuses, right? The T2 imaging, T2 FSE, the image on the left doesn't show any distortions. Whereas you can see that the diffusion imaging shows like a pile up in the frontal cortex. Similarly, you can see how the kidneys are distorted. The one on the left is like, I believe, a haste image. And compared to that, you can see how the kidneys are distorted. So what are the solutions to B0 field inhomogeneity correction? So one option is you can acquire a field map that measures voxel displacement at each voxel, and they usually look like this. You can notice that the voxel displacements are higher when there's like an air-bone tissue interface, and you can use this image to correct for distortions. But this actually takes more time. And what's usually suggested is you can also acquire 2 images with opposing phase encoding directions. And this is how it works. Here's a fetal brain example that we acquired 2 images from a 32-week-old fetus, and this is the fetal brain. And you can see that we are changing the phase encoding direction from AP to PA in this example, or like top up, up down to down up. And you can see how there's like pile up in the left image, whereas in the middle image, which is the opposite phase encoding direction, there's like the opposite, like there's like an enlargement of the volume. So what we can do is what's suggested by Anderson et al. In 2003 is an algorithm called top up. And you can register these 2 images into a middle image. And as you can see, you get like an almost perfect looking image. So one problem with what I have suggested is motion. So this requires, if you go back, this requires that the subject doesn't move between acquisition of 2 images. So our solution was changing the standard diffusion sequence, which acquires like if you go to a diffusion sequence, there's like a 90-degree pulse, there's like a diffusion gradient, 180-degree pulse, another diffusion gradient, and then there is readout. So what we are doing is we are adding like one more readout to this sequence immediately after the first readout in the opposing phase encoding direction. And from these, we can apply the same technology that I described, which is the top up. And what we can show is we have better alignment with the anatomy. So the underlying image here is like a T2-FSE signal. And you see the red contours are the contours coming from the diffusion MRI scan. And as you can see, after motion correction, you can have some alignment, but there are still misalignments between the borders of the T2-FSE and the diffusion scan. And after we correct for motions and distortions, we almost get a perfect alignment. And this actually, you might be wondering, how is distortion important? It becomes very important when you try to calculate quantitative metrics like FA map. And as you can see, if you only correct for motion, there's like, for example, here an artificial increase in the fractional anisotropy map, whereas which can be removed using motion and distortion correction. Here we combine 2 technologies. We combined like real-time motion measurements from an optical tracker plus our dual solutions. And here's the corrected FA and color FA map. And as you can see, although the kid almost moved all the time during the scan, almost 6 degrees and 6 millimeters, we were able to get like a very nice looking FA map and a color FA map. So this works in many body organs. So here's an example from a kidney study that we did in 2021. And here, again, the underlying image is like a structural, I believe, a T1 vibe scan. And here we are showing overlays of green and red. And the green is like one phase encoding direction, and red is the opposing phase encoding direction. And you can see how much the kidneys are moving between these 2 phase encoding directions. And when we apply our sequence with the top-up technology, we can get like an almost perfect alignment with the structural scan. So the final artifact that I would like to talk about is the B1 transmit artifacts. So as the field strength increases, the RF wavelength corresponding to the Larmor frequency decreases. For example, at 3T, RF wavelength in tissue is around 26 centimeters, which is not a problem for the brain because brain is around 26 centimeters, but which is a problem for the fetal MRI. And at 7T, RF wavelength is 11 centimeters, which tells that B1 transmit artifacts are even a problem for brain MRI. So these artifacts result in standing waves, create large variations in signal amplitude. Especially in fetal MRI, increased amniotic fluid can also contribute to these shielding effects. And here's an example. So I want you to concentrate on the images on the right. And here's a T2 haste image. Luckily, the standing wave is not on the image itself. You can see the bottom of the image is all dark, where the fetal body is. So here, but on the axial T2 example, you can see that the frontal cortex is almost dark. And this can actually mimic as like a problem in the frontal cortex of the patient, but actually there's nothing wrong with the patient here. It's just like a signal decay. And when you do, like, for example, gradient echo-based acquisitions, you can see that this artifacts no longer happens. So the current solutions for correcting for B1 artifacts is using dielectric pads and the parallel transmit. Although these are still, I will say, in the research phase. Okay. As I said, one area where B1 transmit artifacts are quite severe is 70 because the RF wavelength is only 11 centimeters. And here's an example from a 70 study that we did on a pediatric patient, 16-year-old epilepsy patient with a prior resection. And if you look at the superior part of the brain, the images look great. There are no artifacts. But as we go to the temporal lobes, you can see that the right temporal lobe here is almost dark and it's like undiagnostic. And one solution to this is called MP2-RAGE. And MP2-RAGE, how does it work? So this is the pulse sequence diagram of your standard T1 weighted MP-RAGE sequence, where you apply like a 180-degree pulse and then you do like a long readout. So what was suggested by Marquez et al. In 2011, I believe, is adding like another whole readout after the first readout, so that you get 2 inversion pulses. And the idea is, especially if you concentrate on the 70 images at the bottom, so you get like one inversion image here and the second inversion image here, which, as you can see, show lots of RF field artifacts. But since they have the same RF field, they were excited by the same RF pulse, they should have the same RF transmit field. So if you do something smart as like combining these with an equation like this, you can see that suddenly the images are almost perfect looking. So there's some problems with the background noise here in these images, but the new software versions actually solve it. Here's an example of how MP2-RAGE actually corrects for these kind of artifacts. And on the left, again, these are from the same subject, 16-year-old epilepsy patients with a prior resection. And the left image is like a T2 space flare image in sagittal view. And as you can see, the temporal lobe is completely gone. And the same slice on the MP2-RAGE image, as you can see, we almost have like a perfect MP2-RAGE image. And I believe this is the end of my talk. So I'd like to acknowledge my funding sources, and I'd like to thank everyone in our lab. So if you have any questions, I'll be happy to answer them.
Excellent lecture, Onur. Was really, really good. And I don't see any questions here. If anyone wants to bring any question now. So I just want to remind everyone, all the people here, that all these lectures, they are being recorded in WFPI and ISMRM. They will be like available soon, the next 2 weeks, so we can access all the lectures there. And again, I would like to thank all the organizers from the WFPI and ISMRM, and thank you, and I hope to see you next time.
Thank you very much.
Thank you.
Thank you. Bye.
Thank you. Bye-bye.